Welcome to this video on the Saint Elevation Triad. We will focus on a bedside ECG differentiation framework for emergency medicine, specifically looking at how to distinguish between STEMI, pericarditis, and benign early repolarization. In this video, we will learn how to recognize the clinical stakes of Saint Elevation mimics. We will apply a structured, 8-step framework to help differentiate these conditions, read morphology patterns, use serial ECGs, and commit to a safe clinical default. Why does this matter? Missing a STEMI delays life-saving reperfusion, while overcalling a mimic exposes patients to unnecessary risks. Because all three conditions can show ST elevation, the ECG is only part of the story. Here is a quick overview. STEMI is a time-critical coronary occlusion. Pericarditis is a diffuse inflammatory process, often post-viral. BER, or benign early repolarization, is a normal ECG variant. Knowing the typical patient population helps guide your initial assessment. This 8-step framework provides a reproducible approach to differentiation. By systematically evaluating context, morphology, lead distribution, and evolution, you can arrive at an accurate diagnosis with greater confidence. Step 1 is clinical context. Look for character of pain, any positional changes, the mode of onset, and specific exam clues like a friction rub. A patient's history and risk factors are crucial first steps in your evaluation. Step 2 is Saint segment morphology. Focus on shape rather than just height. STEMI often presents with a convex tombstone shape, whereas pericarditis is typically diffuse and concave. BER also shows concave elevation, often with J-point notching. Step 3 is lead distribution. Ask yourself, does the elevation fit a single coronary territory? If it doesn't align with a clear vascular distribution, think of a diffuse process like pericarditis rather than an acute occlusion. Step 4 is checking for reciprocal changes. Reciprocal ST depression in anatomically opposite leads is a highly specific sign of a true coronary occlusion and is generally absent in pericarditis and BER. Step 5 covers the PR segment and Spodek sign. Diffuse PR depression is a marker of atrial inflammation specific to pericarditis. Spodek sign, a downward slope of the TP segment, is another useful specific finding. Step 6 is the ST-T-wave ratio in lead V6. If the ratio of J-point elevation to T-wave amplitude is greater than 0.25, it favors pericarditis. A ratio under 0.25 typically points toward benign early repolarization. Step 7 is looking for J-point notching, or the fishhook sign. This is found in the lateral leads for BER. Its presence is very reassuring, though it should still be used in the context of the full clinical picture. Step 8 is evaluating evolution over time. STEMI is dynamic, changing in minutes. Pericarditis evolves over days or weeks, and BER is generally stable. When in doubt, a comparison with an old ECG is your most valuable test. Here is our master comparison table summarizing these features. You can use this as a quick reference when assessing your patients. Keep this guide handy to help distinguish these three patterns effectively. Finally, apply this clinical decision algorithm. If you remain uncertain, always default to the STEMI pathway and consult with cardiology early. Thank you for watching, and remember that safety in clinical decision-making is paramount. Let's review common pitfalls. Avoid anchoring on the idea that a patient is young and healthy. BER can coexist with coronary disease, and young patients can still have a STEMI. Always request a comparison ECG to confirm a static pattern, and remember that troponin and echo are helpful adjuncts, not replacements for clinical judgment. This video features a quick look bedside card. Use this reference to distinguish STEMI, pericarditis, and BER at a glance. It highlights key differentiators like convexity versus concavity, the presence of reciprocal changes, and the ST-T ratio. Feel free to save or print this guide for your clinical practice. To practice these concepts, consider these 3 case vignettes. Each case requires a different interpretation of the clinical findings. Walk through the 8-step framework for each, determine your management plan, and define the appropriate patient disposition. For further learning, consult the authoritative references listed here, including standard emergency medicine textbooks and key cardiology guidelines. Remember that this framework is a tool to support your clinical practice, not a replacement for formal protocols or expert consultation. Thank you for utilizing these resources for your education.